And why does trauma-informed practice matter when treating chronic pain? My far-reaching goal is that every pain program across the country will be trauma-informed. And it seems to be a missing piece in many pain programs, even though this whole concept of trauma-informed care has been around for quite some time. So what does a trauma-informed pain program look like? A trauma-informed pain program is perceived as supportive. It avoids re-traumatizing the person that is experiencing pain. With every interaction from every staff member, from the moment they step foot into a pain program clinic, so with the administrative staff that they may come in contact with, to the physician, to the nurses, the occupational therapist, the social worker, the physical therapist, the nurses, everyone who works at the pain program. It means that the staff of the pain program have an understanding of the triggers of adverse life experience or trauma that oftentimes traditional medical services may make worse for a person seeking pain relief. Trauma-informed care involves understanding the effects of trauma. It means recognizing and responding to the effects of trauma. And that the person with the pain, that whether it was a one-time car accident or if the trauma occurred as a childhood neglect or abuse, it could be complex trauma, that these clues are picked up by the environment, the people working in the pain clinic. Trauma-informed care is centered on principles intended to promote healing and to avoid the risk of re-traumatizing individuals that are already dealing with pain. So why should a pain program bother with providing trauma-informed care? Now, this is our first poll question. So my question to you, and you get a chance to vote with the help of our moderator, Leah, who will help with the poll question. So my question to you is this: what percent of your patients or clients do you think are currently affected by trauma? It could be childhood neglect or abuse, or it could be, an accident, it could be natural disaster. Do you think it was, 10 to 25% of your patients that come through the pain clinic? Or is it 40 to 55%? Or is it even higher, 75 to 90%? So in your environment where you currently work, or with your guests, if you're not working in an environment that's of like a pain clinic, how many people do you think, what percent of people are affected by trauma? And when I say the word trauma, it could be adverse life experience, it could be an extreme negative experience. So pretty soon.
I've closed the polls there, Dr. Caprio.
Oh,
sorry to interrupt. Yep. And we have the results. Let me know if you'd like me to read them out.
Yes.
Okay. Well, we have zero people entered 0 to 25%, but 25% of respondents entered 26 to 50%. 16% of respondents entered 51 to 75%, and 59% of respondents entered 76 to 100%. So it means that most of our participants today believe that there's 76 or higher % of patients and clients that are currently affected by trauma. So that's very significant.
Yeah, that is a very significant number. So, I was really curious about the answer to this question for our patients at the Royal Jubilee Hospital Pain Clinic. So, what I did was an informal survey over a 6-month period leading up to this webinar in anticipation of this very poll question. So, of the 62 people that I informally, anonymously questioned, I got a response out of 58%, or 58 of the 62 people that I surveyed. And the questionnaire I used was the Adverse Childhood Experiences questionnaire. And uh, it has 10 childhood trauma-oriented questions. Previous research using this measure shows that the more adverse childhood experiences result in a higher risk of medical, mental, and social problems as an adult. Many of you are probably familiar with this ACEs, or Adverse Childhood Experiences questionnaire, and I'll actually come back to it later in this presentation. But if out of the 10 questions, if you check 4 or more adverse life experiences, then you have a significantly higher risk for medical, mental, and social problems. So by giving this questionnaire, I found that 55% of the 58 people I informally surveyed, in fact, scored 4 or higher. So 76% is quite high. 55% is telling us a very important piece of information, which means that we have to pay attention. This is a factor that we are missing if we're not noticing. A significant number of people seeking pain relief have been diagnosed formally with post-traumatic stress disorder. In some of the research that has been done, it's been estimated that approximately 35 to 50% of people with chronic pain, or pain lasting more than 6 months, experience enough symptoms of trauma to meet the criteria for post-traumatic stress disorder as indicated in the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders of the American Psychiatric Association. There are many people over and beyond this that have not yet been diagnosed, and they're suffering from adverse or negative life events, but they may not quite meet the criteria. Yet trauma or negative life events and the effects with chronic pain are often unrecognized. They're misdiagnosed, and we tend not to address it in a pain program setting. In my experience, it seems like the presence of trauma when treating chronic pain has not been given sufficient attention. Many of you are likely familiar with the DSM-5 post-traumatic stress disorder criteria, but it is one way to officially identify and standardize what I mean by the word trauma. However, throughout this presentation, I'm referring to adverse and negative life events that cause problems for people. So trauma is it may reach the criteria for a diagnosis of PTSD, but it can still be problematic even if that threshold is not met. A diagnosis of PTSD requires that a traumatic event or events must meet these 5 symptom clusters. And I'm not going to read them out to you because probably many of you are familiar with this. And also, most people actually, even though they're exposed to trauma, do not get post-traumatic stress disorder. In fact, there are approximately 10 to 25% of people that will go on to exhibit enough symptoms after a traumatic event to meet this criteria. Um, so you know, there's a tendency for people to be quite resilient and to recuperate under the right conditions and to get on with their lives. However, as you can see, there are many people as well, especially in the pain environment, that are dealing with enough symptoms of trauma that we need to pay attention. I would like to share with you some examples of people dealing with trauma and chronic pain. And these are people that I've worked with as a psychologist at the pain clinic and also in my private practice. I've changed the personal identifying information for confidentiality to protect people's privacy. And I'm just going to tell you about some people. So I know this slide is not very interesting. It says examples, so you're just going to have to listen to my vignettes here. And I want you to imagine these people as I read them out to you, and I want you to think about some of the people that you're aware of who also may mirror some of what I'm telling you. My first example, he's a 25-year-old man. He was quite severely abused during his childhood, and he became injured while working as a young supervisor for a large manufacturing company. He suffered from CRPS, complex regional pain syndrome, of his right arm. His pain doctor recommended that he receive a stellate ganglion block to treat the CRPS. Now, I know I'm giving you a lot of acronyms here, but a stellate ganglion block requires that a needle be inserted into the sympathetic nerve tissues of the neck. Now, this young man, when he heard what the treatment entailed, he refused to go through it. And he was in excruciating pain. He did not explain to anyone initially why he refused the treatment. He was highly anxious. He would have panic attacks even coming into the pain program clinic. When I was finally able to speak with him about this, and he was willing to share with me, it turned out that the pain doctor, who in fact had a very kind and gentle demeanor, reminded him of the person that had choked him as a child on more than one occasion. And we worked together for several months leading up to the point where he could finally go through the procedure. And we used trauma-specific therapy like exposure and desensitization and other strategies. Finally, he could actually tolerate going through into the procedure room to start and then to actually receive the treatment. So this is one example. Now, my second example is of an elderly woman who it appeared like she would fall asleep during her procedure. And apparently when her pain became quite severe and when the fear levels would go up, she would go away by appearing as if she was sleeping. So during a pain treatment procedure, she would sometimes become unresponsive, even though she had taken no sedative and she was given no sedative. And this was a problem because the doctor needed her to stay awake for feedback during the procedure. During the follow-up session, my follow-up session with her, she described to me a very similar freeze response when she was 10 years old and she was hospitalized for several months without being able to see her parents because of circumstances. So her treatments as a child were very painful, very frightening, and when she would go into a procedure currently at the current time and date, she would have a similar stress response. Now I want to give you a third example. So there's a man, he was hiking in the mountains. He was suddenly shot through his pelvis. He fell to the ground. He's bleeding. He doesn't know who or why there was any gunfire in the area. Before he lost consciousness, he remembers thinking that he was left for dead. And years later, he comes to the pain program. He describes how on occasion when he hears a loud noise that resembles gunfire, he will actually drive, if he's driving, he'll drive to a destination, not necessarily aware of how he got there. And in fact, he described for me how on the previous day when I had seen him, from the time I had seen him, he drove somehow to his doctor's office after hearing a car backfire, and then was told that he had lost consciousness. And he was quite concerned about his mental health, that this kind of experience could exist, and he was quite embarrassed. One more example. Okay, so this is my last example. A middle-aged woman received a pain treatment injection at the pain program, and she insisted on leaving immediately after her procedure, a little bit too early. She started swearing. She made her way down the hall, and of course the other patients and clients were a bit alarmed because of her mannerism. Her medical chart indicated a warning for possible violence. She later described to me how pain and fear triggers a combative reaction. And many of you this may sound familiar to you in terms of how the amygdala is associated with survival rage when it's triggered, when there's intense threat perceived. She described how she had gone into uncontrollable rages that have gotten her in trouble before. But it actually was useful and helpful to her when she was younger. She would fight off her brothers that had sexually abused her throughout her childhood. And it was one way that she protected herself. After she was able to make this connection of why she reacted the way that she did at the pain treatment during her time at the pain clinic, then she was able to apply some trauma-specific strategies that helped her to tolerate the distress of the procedure. And it was really helpful when the nurse purposefully created an environment of perceived safety. So these are 4 examples that I want you to keep in mind during the rest of this presentation. How does a person dealing with PTSD or trauma present, even without chronic pain? The clinical presentation of PTSD is quite varied. There could be a fear-based response in emotion, in behavior. There can be just a dysphoric mood and a lack of enjoyment. There could just be negative thinking. It may be that there's hyperarousal of the sympathetic nervous system, where there's a lot of reactivity to loud noises. There's a heightened startled response and sensitivity to sound and light. Or there can also be a shutdown mode of non-responsiveness, where a person may appear to just go away and dissociate. The epidemiology, some of the facts I think are relevant. By the time a person is 75 years old, 8.7% of people meet the criteria for PTSD. We know that if a person has a diagnosis of PTSD, this increases the risk for suicide. PTSD is more prevalent among females. Across the lifespan, almost 1 in 5 women have been sexually attacked. And of these 1 in 5 women, half of them have a prevalence of trauma that meets the criteria for PTSD. And of course, there are some vocations that increases the risk of PTSD. So it can be an occupational hazard for many. The functional consequences of PTSD are far-reaching. Poor social family relationships, increased risk of health problems, dependency and substance abuse, inability to maintain a job and to keep a consistent employment, lower educational success, and of course then lower income. PTSD has significant public health implications, and also this overlaps with people that are managing chronic pain. For those that are experiencing both trauma and chronic pain, there's a double hit. There's greater frequency of health problems, more pain-related disability, higher pain ratings, increased functional impairment, higher rates of healthcare utilization and costs. This is all significant enough that we do need to pay attention. There are several models that help to explain the relationship between trauma and chronic pain, but these require more time than we have today, and we're going to need a follow-up webinar if there's interest to go further into these models. I wanted to stay on a more practical level here. Here are some of the shared clinical features of trauma and chronic pain. There's an attentional bias that is a learned tendency to focus on certain stimuli, both internal to the person and external, and this results in greater attention to any kind of threat or painful stimuli. So it could be an external threat like loud noise, or it could be an internal threat like pain, or even a memory. Those with chronic pain and trauma or PTSD may demonstrate an increased sensitivity to anxiety's physiological symptoms. They may tend to catastrophize, to expect the worst, to a greater extent than those with either one or the other, only trauma or only pain. The physical sensation of pain can be perceived as a reminder to the traumatic event, and pain can be misperceived or perceived as an indication of physical damage. This may trigger the shared tendency of PTSD and pain toward avoidance as a primary coping strategy. There can be hyperarousal of the nervous system with both PTSD. A traumatic memory can trigger a pain response, and experiencing pain can trigger a traumatic memory. So cognitive resources become depleted. Fatigue, general anxiety may result from these shared factors and contribute to physiological and psychological exhaustion or discomfort, catastrophizing tendencies, and a tendency to use avoidant coping. There's a shared physiological stress response for both trauma and pain, involving many parts of the brain: the anterior cingulate cortex, the hippocampus, the ventral medial prefrontal cortex, the amygdala that we had mentioned earlier. With both pain and trauma, there is activation of the HPA axis, which is part of the stress response, and then you get the dump of stress hormones. Understanding the presence of trauma for people dealing with pain can make a significant difference in the success of the treatment for pain. And I've seen this frequently at the pain clinic. It may be, though, that those people that seem to be stuck or resistant in some way to treatment for chronic pain are actually dealing with symptoms of trauma. And this needs to be addressed as a part of a treatment plan. And it's also consistent with our biopsychosocial approach as a comprehensive pain, as all comprehensive pain programs should be. We need to educate ourselves about trauma and the symptoms of PTSD. We need to recognize when trauma may be a factor affecting a person's treatment for pain. How might a person with symptoms of trauma present? Well, sitting in the waiting area, let's say of the pain program, while they're preparing for a medical procedure, or while they're leaving after a procedure or during the procedure. How might the symptoms of trauma or PTSD present when a person is attempting to participate in one of the self-management components of a pain program? Many pain programs have a self-management component whereby it might be a group setting or it may be individualized. And how would you pick up the clues? Which brings us to our second poll question. And that is, how may a person with trauma present while they participate at a pain program? You know, what are the symptoms? What are the clues? A could be uncooperative. B, they may appear angry. C, they may appear avoidant of stimulation. May sit back of the room. They may come in and turn the lights off. Or D, all of the above. So how might a person look?
Well, Dr. Caprio, it looks like everybody answered 100% all of the above.
Okay, that was too easy. So this may seem relatively obvious, but as you will see, some clues may not be so evident. Here are some examples of what you may see and hear from a person dealing with both trauma and pain. Again, I've changed the personal identifying information for confidentiality. So in this, the top example, an injection has to be rescheduled because the patient's too emotionally upset to complete a relatively painless procedure. And this person, even if they had the procedure done, it takes them twice as long to recover, enough to even leave the pain clinic. Another example, you might hear some words along these lines. And these are quotes of actual situations. So this person says, this pain makes me feel desperate, like when my cousin abused me. I can't get away from it. Makes me nauseous when my pain goes around a 5 out of 10. I just want to run. So you know that whole sympathetic nervous system activation stress response has been activated. The next example, walking into the group room, too overwhelming. I sit at the back and I try to tune out the lights and the noise. Whenever my pain awakens me, I remember what it was like waiting for help after the accident. I didn't think they were going to come back to get me. And another example, I tried doing my physical therapy, but when the pain increases, I remember the beatings and not being able to protect myself. I know it was a long time ago, but I panic and freeze. I may look calm, but I feel like I'm dying. And in my last example, I get flashbacks of the dead children and then a surge of pain in my arm. How can that be? And the person who said this was followed up by many people saying something very similar, whereby they experience a pain and it brings them back to the traumatic event. And the people that have said these types of experiences have in fact been protectors of others. We're there to protect and to serve. And so it was very disturbing to them that they would have this kind of response. Now, I would like to show you a slide deck from Egloff and Hershey on an explanatory model that they came up with for trauma and pain. And please bear with me while I see if I can get my technology to do what I need. Okay, so Egloff and Hershey, they are researchers, clinicians in Switzerland. And they work with victims of torture and military personnel. They developed this illustration to explain trauma-associated pain, where the body develops an alarm system, an alarm mechanism with hypersensitivity to any form of threat and stress, which of course includes pain. They developed this explanatory model to help explain to their patients their symptoms and the experience of pain and trauma. So I am going to click through this once I got almost caught by an eagle. And you're probably seeing the pictures of extreme distress. The poor rabbit. My body has two strategies to protect me from this happening again. Hypernesia. The first is never to forget this danger. Keep a firm recollection of this experience, even of pain. Remember what it looked like, sounded like, felt like, all the clues. The second strategy is to sharpen all senses. My ears are like a radar now. My eyes already alert me if an object resembles an eagle slightly. So the rabbit sees a kite. Hypersensitivity. My body is already alarmed by a simple bite of a flea, and I can feel the claws of the eagle in my fur again. Hypersensitivity. But if something reminds me too much of an eagle, dissociation. I turn into stone. Flashback. Aggression. I realize I have become more aggressive. Could this happen to me to better defend myself against an eagle's attack in the future? Hypernesia, hypersensitivity, and aggression are there to help me to better ward off an eagle's threat in the future. So it serves a purpose. But I'd rather be a simple rabbit again. In 1992, Judith Herman published her very well-known book now, Trauma and Recovery. Many of you are probably familiar with it. She suggested that trauma was a response to a wide range of experiences, not just limited to war or natural disasters. She described how trauma and the traumatic reactions could also be related to experiences of physical, sexual abuse, childhood neglect, assault as an adult, domestic violence, and unexpected losses. And since then, many researchers have continued to expand on Herman's work to understand this relationship between trauma, physical health symptoms, chronic pain, and substance use. Vincent Folletti's Adverse Childhood Experiences study that I had mentioned earlier was actually termed one of the most important public health studies. It started out interestingly enough, as an obesity study while he was the chief of preventative medicine in San Diego, California. And it became evident that there was a direct link between childhood trauma and adult onset of chronic disease, mental illness, and substance use. He found that the more adverse childhood experiences, the higher the risk of medical, mental, and social problems as an adult. And principles of attachment theory have been a noticeable thread throughout much of this research. As a result of this line of research, trauma-informed practices and guidelines started developing through Canada, the US, and England, or all through Europe. What is trauma-informed care? Well, it's based on understanding the triggers of trauma that traditional medical service delivery approaches may actually make worse, not meaning to, but can actually exacerbate, so that our pain interventions, we want them to be more supportive and to avoid re-traumatizing the person that's experiencing the pain. Trauma-informed care is an organizational structure, and it's a treatment framework. It involves understanding, recognizing, and responding to the effects of trauma. It's centered on principles intended to promote healing and to reduce the risk of re-traumatization for individuals. And, individuals aren't necessarily vulnerable. It's that we are human, and we have to be aware of how our nervous system, how our brain, how our bodies react under circumstances. Trauma-informed care means that we recognize that some problematic behaviors actually may reflect coping strategies that were intended to increase survival at an earlier point. Problem behaviors are therefore understood as attempts to cope with traumatic experiences. So disorders from this perspective actually become responses. And the symptoms that we see that appear problematic, they're actually adaptations. The question shifts then from not what is wrong with this person, but rather what happened to this person. Which brings us to our third poll question, and that is it important to know the details of the trauma to be helpful to the patient or the client? A, true, B, false. Do we need, as healthcare professionals, as a person working in a pain clinic or dealing with a person who has chronic pain, persistent pain, is it important that that you know what the trauma is and the details about that trauma? A, if you agree, and B, if you disagree or you think that's false. So,
okay, just closing the poll now. We've had lots of answers.
Okay.
Do you want me to read them out, Dr. Caprio?
Yes, please.
Sure. So we had 48% said true and 58% said false, and it really kind of vacillated between those two. So maybe you can help us there.
Okay. Well, thank you for everyone who's voting. That's interesting. It's pretty well split down the middle. Okay, so staff does not actually solicit or go into details of the trauma with the client in a trauma-informed clinic or using trauma-informed care. Disclosure is not required. The focus is actually not on a diagnosis or on the specific nature of the traumatic event. The focus in a pain clinic environment is to increase the client's sense of safety by developing, helping them to develop some sense of self-management skills for grounding, for feeling safe in some way, for feeling connected. The job of the staff of a pain clinic is to actually identify trauma symptoms, or I prefer the word adaptations because symptoms almost sounds like there's something wrong. Adaptation shows that there was a purpose for these behaviors. The job of the staff is to offer supports and strategies that increase safety and connections to others. So it might be in the immediate environment, or it might be once they leave, like resources outside the pain clinic. It's important to know, however, when to make a referral for trauma-specific services, such as if the trauma is a barrier for receiving a medical procedure or interfering with the ability to benefit from the pain program self-management. So, in other words, the pain program needs to be trauma-informed across the board. To make a referral for trauma-specific interventions where it appears that person needs to go deeper into what the trauma is so that they can benefit from the self-management group component of the pain program, or for them to be able to tolerate a procedure, that's where a referral for trauma-specific interventions need to be made. And this is with a person who has specialized treatment in this area. It's designed to address the consequences of trauma, to alleviate some of the suffering, and to alleviate some of the symptoms. So some of the treatments might include neurofeedback or eye movement desensitization and reprocessing, imagery rehearsal therapy, exposure therapy, even virtual reality. These are some of the trauma-specific interventions. In my role as a psychologist at the pain clinic, I implement trauma-specific interventions with people if it's apparent that trauma is a barrier for them being able to receive a medical procedure, or for a person being able to tolerate participation in the self-management aspect of our pain program. Specialized training is required for trauma-specific treatment. So it's not necessary for everybody to know how to implement trauma-specific therapy. Now, I have another. This is our last poll question, and the question is this: do you use an assessment measure to determine the presence or the extent of trauma in your role in working with people who are dealing with pain? And it could be, I've put down some examples as adverse childhood experiences with Vincent Folletti's questionnaire, or it could be the DAPS, the Detailed Assessment of Post-Traumatic Stress, or the PCL-5 is another one that's in alignment with the DSM-5. Do you use an assessment measure? And it probably directly depends upon your role in your role in dealing with chronic pain.
These are very interesting results. I'm going to close the poll. Thank you, everybody. So we have 19% said yes and 81% said no.
Okay. And, you know, that makes sense in part because the majority of people that work as staff in a pain clinic, in fact, are the support, have other roles other than trauma-specific therapy. So, you know, as a nurse, as administrative staff, to be aware that trauma behavior, what that looks like, is important but to really know the details of what that person went through that might be causing the trauma would be less relevant, perhaps. And actually I take away the word perhaps, because really where it is relevant is with the trauma-specific therapy. You would like to get the details so that you can work very directly with the trauma, depending upon what type of therapy you're using. I'm actually pleasantly surprised to see the 19%. It's actually a bit higher than I thought. And that tells me with some relief, I guess, that trauma is being paid attention to in a pain environment where pain is being treated. So I'm actually quite pleased to see that. Trauma-informed care, it means that the work is focused at all levels of from the organizational level, if that's relevant, on down to the clinic, to the staff, right to the patient. And it focuses on being aware of the trauma, on creating a sense of safety. And this includes trustworthiness. How are you perceived by the patients, the clients that come to you with chronic pain? It means that as well that you, trauma-informed care means that you're building on their strengths and their skills. So anyone who comes with pain also has coping mechanisms. You have to know what those are and tap into them. And what's really interesting and what I've noticed is that the more pain or the more trauma-informed an environment is, the more you will hear discussion amongst the staff around trauma, the person's experience of their own pain. Mental health will be acknowledged as being a normal part of the conversation, along with substance use and addictive behaviors and how that ties in with the overall picture in dealing with pain and trauma. There are many developed frameworks out there that have thoroughly outlined what trauma-informed care looks like. This is not a new idea. It's been around for a long time. We need to integrate it and increase our level of professionalism and expertise and understanding of chronic pain and how trauma is a part of the picture. So these are a couple of resources. The Trauma-Informed Practice Guide, BC Provincial Mental Health and Substance Use Planning Council, and also the Gendering the National Framework. This is also an extensive resource of information around trauma-informed care. And also becoming trauma-informed, you're probably familiar with many of these, and the National Center for Trauma-Informed Care and SAMHSA, the Substance Abuse and Mental Health Services Administration. So we don't have to reinvent the wheel here. We can utilize what is already out there and bring it into our environment and our expertise. We need to increase the awareness that many people managing pain are affected by trauma. Trauma-informed care needs to be at the center of any pain program. So now if you have some questions that have come up, or even a comment that you would like to contribute, I know that Leah is helping us compile that.
Thanks, Dr. Caprio. We've had a few questions, actually, and there's still a chance, even though we're short on time here, there's still a chance to enter more questions, but maybe I can read out a few of these questions for you, Dr. Caprio. The first one we had is, I'm a nurse. What does trauma-informed care look like for nurses? Can you give us some examples there?
Okay. Um, Thank you for that question. Okay, okay, at the core, this does not need to be complicated. Sometimes I think that we minimize what we already know. Safety is number one. If a patient perceives that they are safe, that they are cared for, that they are seen, and that their concerns are being addressed, they will be calmer. Their stress response, that whole HPA axis sympathetic nervous system reactivity, will not be triggered. And it can be something as simple as the tone of your voice, um, of how you move in their space. If a person has been physically harmed in some way, they will be reactive to someone coming into their space, and they may not be aware of it consciously. As we know, the amygdala, or that blind rage that occurs, that part of our brain in the limbic system that wants to protect us, it doesn't think, it just reacts. And it connects with the other parts of the brain that think later. And it may be a few seconds later, but already the stress response has been triggered. So it might just be a reassuring a smile, just an acknowledgement, letting them know that you see them and that you're aware of who they are. Um, and if I can also say, I know we're kind of short on time, but also just by giving the patient information about their procedure can make a huge difference. We know that the stress response gets triggered when people feel they perceive a lack of control with something really important to them. Many people coming to the pain clinic, when they go through a procedure, that's important. If they feel like they have some sense of control by having the information, their stress level is less, they're less reactive. So information is also another way of that you can reassure and create a trauma-informed environment as a nurse.
Thank you, Dr. Caprio. We've had a few more questions, if you don't mind just answering them quickly. We have one here. I'm just going to read it out. This is an excellent presentation. Could you comment on how to overcome the barriers to accessing MSP-covered mental health services for trauma? This person mentions that pain program waiting lists are very long.
So how to access, okay, can you just read that question for me one more time, because there's several ways I could go with this.
So they're just asking, what are some ways to overcome the barriers to accessing MSP-covered services? So what are some other options out there?
Yeah, well, I know that this is we're really working hard. I know as psychologists trying to get the coverage through MSP to make access more available. I think this speaks to the whole question around mental health and how we're going to see a big push in years to come for mental health being addressed, and so making sure that those barriers are not there. I do want to mention that here at the Royal Jubilee Hospital, I can speak specifically that you can immediately, as a community person, a person in pain, you don't even need a referral. You can come to the pain clinic for an orientation Tuesday at 4 o'clock, and it's almost every Tuesday, every Tuesday of the year, and there's an orientation for a couple hours speaking around chronic pain and the services that are available. Also, we also know that if you can get into your family doctor, have your family doctor make a referral to the pain clinic, and again, I can speak for the Royal Jubilee Hospital. They can either ask for a self-management referral and or to be seen by a family or by a physician here at the pain clinic. If they are referred by their family doctor, they can almost immediately get into the self-management part of the pain clinic. So I think that the barriers for treatment around pain are less than what people know, and we need to get the word out there.
Great, thank you so much. We have had a few other questions. They're great ones. What I'll do, though, is we'll just wrap up the webinar for today, and I'll forward your questions to Dr. Caprio, and we'll get those answers back to you. So thank you so much for participating, and please do take a few seconds to enter your feedback in our post-event survey. It's your chance to sign up for future educational events, and we've got another webinar coming up next month. You can also get in touch with us at education@painbc.ca. So thank you very much for your participation. Thank you, Dr. Caprio. It was a great session. Have a wonderful afternoon. Bye-bye, everyone.